This is a presentation by Clinical Eye Openers. I am Dr. Werteleki, shown here, and all the contributions in these series are by the members of OMNI-Net listed here. You may find more details at this particular website concerning clinical eye openers as well as other related websites. This is one of the Believe It or Not stories, and it is concerned primarily with the process of clinical discovery. How does one suspect that a patient may have a unique or novel medical disorder? We emphasize issues to remember, and therefore we recommend that you stop the motion and repeat viewing certain portions because of the extensive use of terminology that is explained elsewhere. In this sense, I think we will use this emblem to underscore the point that there are many more known diagnoses than new ones, but that there is a tendency to try to fit a foot in the wrong shoe is called the hyperdiagnosis. So one should be very careful with this sort of attitude, like this is a warning, and that one should avoid at all costs to fall into the pitfall of overdiagnosis. It's just as bad as missing a diagnosis. So this particular story is about an investigation of skin fragility and whether it represents a new quote-unquote syndrome or human disorder. There are concepts that we are going to rely upon that we wish to mention just briefly so you are prepared to note them more readily. The natural history is a term that is rarely used in clinical medicine, but it is extremely useful because it is objective. It's all what's happening naturally before, during, and after one encounters with a patient. The subject is an object, and one has to be objective. The objective are the signs. So signs a clinician collects as an objective definition of a subject. The interpretation of signs through knowledge generates signals, but knowledge is abstract, and then signs become abstracts. They become subjective. So is the notion of what happened. How is it expressing that way? How is this baby becoming the way it is? What is the synthesis of what we know about the process, cause, circumstances, the prospects, and the prospects then fall within the domain of the natural history. These are hypothetical issues. What actually happens is subjective. So here is an example where one may have to stop and read this at leisure, and I have to be brief here, so therefore I will only touch very superficially on these points, and I think one should come back and cogitate of what truly are the deeper meanings of these notions. One has to ensure that we have a full house, a complete array of collection of signs, and that these are objective, that they are not false signs, false smoke signals. So 2 points: objective and full house, full evidence. One has to be aware that having a preconception of a diagnosis will distort the whole process, and that process, whatever it is the natural history. If we don't know the objective natural history, we know nothing about the patient. And that includes not just the patient, but the whole background from where it was generated, the extended families, genetic or social, the habitat. They should be fully explored. Atypical observations call for a clinicians to review the experience of others. One has to ensure that the natural history is not in conflict with a hypothetical diagnosis. If the hypothetical diagnosis is Down syndrome and the natural history says that the patient was elected to the Academy of Sciences, there is some degree of incompatibility. And in the case of incompatibility, natural history is a higher order of truth. One has to avoid hyperdiagnosis at all costs. Don't fit wrong feet in the wrong shoe. It may make the clinician feel very competent, but it does not help the patient. Here, I continue with these somewhat abstract concepts, but a little bit faster, so you need to come back, stop the motion, read these at leisure. But the point is that true science must be objective, not distorted by preconceptions. And preconceptions will result in false negative because they don't fit preconceptions, or false positive science because you want to be a hero. So please read this. But the main point again is that the natural history is a higher order of truth. So we are ready to start. Here is the subject. What are the undistorted signs? It all started with what I felt was an extraordinary baby. Extraordinary because nobody saw one like it. And I could not find that reported in the casuistics or clinical medical reports. This was so concerning several very experienced neonatologists, clinicians, etc. So what did this artist see? This artist is not a physician, is not a clinician. So I asked her to make a drawing and say, draw what calls your attention. And she drew micrognathia, sagging cheeks, sagging tissue, and what called her very strong attention was that she said it's like a harmonica, or like a fallen sock's skin is lax. It just fell down. Well, but there is more to it. Can you see? Can you open your eyes? I will let you look, and thereafter I will be faster. So if you want to take longer looks or open your eyes for longer, then stop the motion every time there is an image. So what do I see in addition to what was mentioned earlier? I see a puffiness around the eye, and this is a particularly soft tissue prone to swelling due to other causes, which suggests that the contents in this tissue is different than the contents, let's say, in the scalp. And on the right, the artist was very provoked by what she said. It looks like a harmonica. It looks like the skin fell down, like fallen socks. And in addition, note the protrusions through the skin of under the skin or subdermal tissues. It's almost like multiple hernias. So in the next few slides you can soak in what you see. This is reality. These are real signs. Call it accordion skin or whatever have you. But if you open your eyes further and further, you may feel that maybe the distal portion of the toes is short and so on. So keep your eyes open. Here is the baby shortly after birth. This is reality. There are no hematomas, and I will whisper into your ear that, yeah, hematomas will appear, but not now, later. You could see how the baby appeared to the neonatologist, who were puzzled and asked me to see this particular patient. Obviously, this means that the patient had difficulty with being fed. This is this patient upon discharge. So obviously it's a tiny baby, probably born prematurely. You could see the facial proportions, you see the prominent periocular soft tissue, you see the small chin. But what else do you see? No hematomas, hematomas later. Open your eyes before I tell you. So this brings me to suggest that you should replay this as many times as you wish. There will be a lot of words shown that you can read them leisurely later or look them up, and keep trying to soak in what you see. So here is what I can add then. The anamnesis, that means, ana means to cut off, what the patient could cut out of his memory and tell us to our memory, whatever it was in the memory of the informants, and whatever happened in the early clinical examination is summarized here. That it was a short gestation, there was no particular problems during the pregnancy except a premature rupture of the membranes, and you can read all of this. We cannot see all of this here, we can see only some of it, but there is something important that we can see. These bones are straight, these fingers are straight, these are not long, and the baby did not grow much since birth. So again, open your eyes, and I will rush, but you can stop the motion and look as long as you wish. For instance, you could say that the antihelix of the ear is more prominent than the helix that hides behind. That's an example. And what I will call your attention to then is that these tubular bones are short, that there is no bending, that there is no history of fractures, and that there is no hypermobility of the joints. Loose words create problems, and you're going to find many subsequent reports to this original one where people very lightly say that the joints are hyperextensible. That is quite questionable. So open your eyes. Here is she a little bit later. She obviously is well connected. She's talking to us with her expression. What happened here? What is all of this? Good prehension, perhaps. Maybe she's sharing a little toy. So here is the natural history since birth up to a few months of life. She has a normal intellectual development. She has severe myopia. She has profuse hair, scalp hair. And gradually increasing, that skin becomes saggy. And in the process, she developed 2 subdural hematomas without history of trauma. And she also avulsed or split her skin, which healed normally, and in one occasion at least left no scar. The skin is like jelly. It's almost like embryonic skin that heals fully. Open your eyes. What do you see? This is a patient that you have been called to see, and you're following up this patient a few months later. Well, the micrognathia is less prominent. This is a little bit less prominent. But what is clearly is that that and this may be a sign that signals something. So unquestionably, the sclera is blue because it's thin. Unquestionably, she has myopia because her ocular globe is too big, it's too soft, and the cornea is too big. So it's not a megacornea structurally, it's a megacornea because it is soft. So there is some defective element in her tissue of the ocular globe. And here she is just about at the same time. Open your eyes. What do you see? What do you see here? What do you see here or here or here? This particular feature or sign is not only present in her but was noted soon after we reported her in another patient, so it may be a consistent sign. Why would this grow so generously? Good question. And why would the hematomas appear after some time and not at the time of birth? And the sagging skin with the herniation. Multiple recurring hematomas, subdural hematoma, a very soft scar, and lax skin, which is not the same as hyperelastic. You pull, you break. Let's focus a little bit more on a component of the previous images. Here we are pulling the skin and it shows you that it's like dough, like soft clay. That is not equivalent to hyperelastic. It is essentially lack of resistance, and if you keep pulling you're going to end up holding it. It's going to tear off and there's going to be a huge skin gap, following which you can stitch it back together and you're going to get normal quick healing, but the scar is going to be minimal if any. In some early wounds the scar was virtually absent, like if it was the skin of an embryo. The point here is that this degree of trauma or fragility of tearing off the skin was virtually trauma-free. So as this baby was picked up by parents, often they ended up with small pieces of skin on their fingers. So here is the terminology. So we're talking about the skin, dermis. Sparaxis in Greek means tearing, something that you can tear off, like in a calendar pages. And then healing, which you call in vernacular scar, and in medical, you call it in medical terminology cicatrix. So this is important because this is one of the cardinal signs observed in this patient. Open your eyes. I'm going to tell you very little about this except for one remark. This is called volar skin or friction skin, and it is a very specialized organ of humans and primates and even other mammals. One characteristic is that the sweat pores here do not react to heat, but react to stress. It is to enhance the grasp, the capacity of primates to fly from tree to tree. They have these volar skins on their prehensile tails. The feet have the same. And of course, this is the area where you're going to have fingerprints. And here you see many what's called white lines, and that's used in forensic medicine. So what do we see here then? We see these herniations. This is called the volar skin or friction skin. And there's an excess of these creases. Herniations. And creases. And shortness. Short and broad nails. But they're not fragile. There are no fractures and the nails are not fragile. Those are facts. So once we have a series of signs and we have the natural history preceding our examination, we find that this child is the product of consanguinity and there are other factors in the family. That's called catamnesis, that is, all the facts accumulated for, in this instance, for 36 months of postnatal life. Kata is what to falls, amnesis is what we remember, or what is befallen, or what was your destiny loaded with, and what do you remember. All of these, through the intellectual apparatus of clinical knowledge, may or may not be signals of something that you think it may be. So what are these signals? Well, here's one signal, here's another, and another, and there are signals. But how do I put them together? I have a lot of signals. Well, fine. You could say signals that run together are a syndrome. So what's this syndrome about? How do you lump them? How do you interconnect them? So you start saying, well, gee, I don't know what this is, but perhaps I have a hypothesis. Collagen. Collagen is the body glue and is most abundant in the skin. So let's think about collagen for a while. So we have a hypothesis. Based on what I know about similar cases from the casuistics or clinical medical sciences report, I am interested in similarities that may exist between this patient and other patients with collagen disorders. After all, collagen is the most abundant protein in skin, 70%, and it is distributed a lot across other tissues, which then brings now the issue of satellite examination, satellite search for signs and signals. So, for instance, I forgot to think that if collagen exists in arteries, does my patient have problems with arteries? Let's suppose that she has a renal artery problem. Is she hypertensive? So I'm going to be expanding the collection of signs and considering some of them as perhaps supportive signals of collagen hypothesis or supportive or not supportive of this particular point of view. And if I'm going to persist in my hypothesis of collagen, I should be aware that collagen is the product of many, many genes and gene interactions or post-translational events after the synthesis of one particular gene. Other genes may interfere or change or metamorphose the products. So the casuistics review has to take into account a great deal of clinical variability. And then for practical purposes, I may focus on the casuistics or reports of the most and best known phenotypes or examples of clinical collagen disorders, for instance, Marfan syndrome. And I find that my patient doesn't look like an instance of this complex. I will also come across Ehlers-Danlos complex. Well, it fits a little bit, but my patient doesn't fit in any old shoe, and is pushing it into that situation would be unfair. There's another prominent collagen disorder called osteogenesis imperfecta associated with fractures. Well, my patient doesn't have fractures, and so on and so on. So I may have to go to casuistics beyond humans. I may have to look at similar phenotypes in other species like sheep, cattle, cats, and so on. And to my surprise, there it is. There are a lot of examples in diverse species of mammals that had very similar signs and therefore conducive to similar signals. And I ought to study this literature very carefully. So the hypothesis of collagen as far as pathogenesis is concerned stands, but it doesn't tell me much about the etiology. The etiology probably are gene mutations. So am I going to test this by a genome test? Not really. I know that collagen has specific morphologic structure, so perhaps I ought to look at the electron microscope structure of collagen. And here it is. We see a transection of collagen fibers and longitudinal view. And here is a skin biopsy of my patient, and they're completely different. So I can conclude then that the patient, instead of having normal bundles, has ribbon or hieroglyphic-like disruptions of collagen fibers. And so this probably is one of a unique feature of this particular condition, where among the diagnostic criteria may be an electron microscopy examination of a skin biopsy, rather than doing complex genomic analyses, since we are looking at any number of potential genes are not likely to be giving us a very specific answer. Well, let's put all of that together, and we find from the veterinary literature the term dermatosparaxis, which is skin that tears. Sparaxis is tearing, and dermato is skin. And we report this patient in 1992 as an initial observation of dermatosparaxis in humans. So this stands then arguably as the very first report in a human of this particular disorder. Well, but one case doesn't stand for the whole of Rome. So what are the lessons learned? Well, we learned a lot from one patient with dermatosparaxis. We emphasized that signs are objective and that signals such as synthesis of pathogenesis, diagnosis are hypothetical. That the etiology could be objective, but most of the time is also hypothetical. That the natural history must be compatible with whatever diagnosis we propose, and at the very early stage the cattle survived, so did this patient. The natural history subsequently could invalidate the diagnosis if it was not in accordance to what's known. These hypotheticals and natural history have to be entirely compatible. The animal survived, the patient survived. The gathering of signs must be objective, without diagnosis preconception, otherwise you distort the process and invalidate the conclusions. Preconceptions mislead notions of etiology, pathogenesis, or diagnosis. We learned that, and we reaffirmed that through this particular one patient observation. So following our report in 1992, as stated earlier, there was a plethora of reports that followed. And therefore, there is a whole pool of further observations that allow further analysis. If there is sufficient clinical reports, one could then attempt a synthesis of casuistics, and that is case experience, responses to different therapies, repercussions on overall research approaches. Is it all going to be genomic? Is there going to be some biochemistry and so forth? Patterns of citation and credits. Sociologists may be interested in, let's say, gangsterism in the field of academia. Friends citing friends, ignoring reports by competitors, created financial incompatibilities. The impact of for-profit medical journals. What do they like to publish or not publish? The review of scientific contributions is anonymous, so reviewers can be unfair with impunity. Or it could even lead to research of how fair and unbiased is the media. I noticed, for example, that leading search engines of the web, if I search for images of Dermatosparaxis, I don't find those we publish. I find others that are far more dramatic but inappropriate, and so forth. So it lends itself to a lot of further pursuits. So with a little bit of humor, let's go back to our old shoe and let's discard it. I think based on our observations, and knowing that our patient is treasure because the patient represents an exception to the rule of what we normally recognize, and our willingness to share that with our colleagues in the world, we need a new shoe, a fancy new shoe, not to squeeze a foot that doesn't fit in an old shoe, but create a new shoe for a new foot, or let's say a new clinical conditions. Clinicians should reassert their primacy because clinical observations have led far more to molecular discoveries than vice versa. Let me repeat this. Clinical observations led to the discovery of many more genes and genetic mechanisms than molecular investigations translated into clinical observations. And that is an important fact that is underappreciated. So this leads us then to the end. I wish to thank you for your attention, and I really hope that you will visit us soon again and often. Thank you again.